Open the meeting of Health Human Services Oversight Committee for Friday, the 22nd of November, 2024. And would the clerk please call the roll?
Representative Pearson.
Here.
Representative Weber.
Here.
Representative Edwards.
Here.
Representative King. Here. Representative Merchant.
Here.
Representative McDonald. Representative Murphy. Senator Gray. Senator Rosenwald. And Senator Avard.
Senator Rosenbaum's people sent an excuse ahead of time, so it's an excused absence.
Okay.
Thank you. Approval of the minutes from October 25th regular meeting. You should have gotten them by email. Any questions? I'm looking for an approval. I'm also looking for them. Well, they've been buried.
It would
Well,
look like this.
I need to get my copy. Yes, it's draft on it. Thank you. I've already looked at it.
Is that a motion to approve? Second.
Motion and second to approve. Any further discussion? All in favor?
Aye.
Opposed? DHHS Commissioners Update. The dynamic threesome of Deputy Commissioner Dr. Melissa Henn, our, I don't say old friend, but friend of many years standing, Henry Littman and Wendy Altman, and everybody come on up eventually.
Good morning, Marissa Henn, Deputy Commissioner. Thanks so much, Chairman Pearson. I think what we'll do is I'll give a little overview of our play in 3 acts and then invite the different individuals from the department to come forward, since we have a nice array of updates for you today. So here's what I'm thinking, is that we will first I'll give a little overview and then we'll have them come up. We'll first talk about the system of care for aging, for healthy aging specifically, by having Associate Commissioner Chris Santinello, as well as our Bureau Chief Wendy Altman from the Bureau for Adult and Aging Services come up, give a couple minutes. Then we'll have Henry Littman, our Director of the Division for Medicaid Services, as well as Associate Commissioner Ann Landry, come up to talk about both community reentry as well as Medicaid for through the schools. And then I will close out with a little bit of an update on the 2 reports that you requested information on. Does that sound okay?
We've got the room till 3 p.m.
Okay. My hope is that we can actually be super efficient and maybe keep all of this to 10 or 15 minutes to avoid folks needing to be here all day. So with that, I will invite Chris Santinello and Wendy Altman to come join me here, and I'll get a 3rd seat so we can all be up together.
We need a much larger testifying table with more microphones.
Chair. Oh, you guys take the 2 there. I'm not, yeah, I'm like, what?
Attorney Williams, can you make that happen? What's that?
I believe that you just have to ask for it.
And you shall receive.
Seek and I shall find. I'll do it.
Good morning. Like Deputy Commissioner said, I'm Chris Santinello, Associate Commissioner, joined here by Wendy Altman, who is our Bureau Chief for Adult and Aging Services, formerly known as Adult and Elderly and Adult Services. So in our current biennium, the system of care for healthy aging was included in HB2, and this provided the department a significant opportunity to strengthen our system of care for adults who are aging in the state of New Hampshire. And so Wendy did submit the annual report to this committee November 1st, but I just asked her to kind of just give a high-level overview of the work and what we're doing.
And
Thank you.
let us know what the document looks like, because we have lots of them. Oh,
Very pretty.
this one?
Yes, hi, Wendy Altman, Bureau Chief for the Bureau of Adult and Aging Services. With you today, just really quickly, is a very high-level overview snapshot of information that we've provided as part of the annual report, just to talk about the progress that we've made over the last 1.5 years for our system of care for healthy aging. And first, we wanted to just point to the visual diagram. This is part of our annual report, but it's also something that we worked collaboratively on with the Commission on Aging to really develop a visual to describe how we are also part of the DHHS roadmap, as well as the elements and vision for system of care. We talk a lot about that a little bit more in a little bit more detail in the annual report, but the focus that I wanted to try to get to today is around what we've completed in that progress and what we're doing next. We completed over the last year and a half implementation of the rate increases that were part of HB2 for our Choices for Independence waiver program. We also implemented and began to operationalize last January the eligibility changes that were part of the bill. We've re-procured our Aging and Disability Resource Center contracts and included several elements within the system of care into their contracts. Yes, and Aging and Disability Resource Centers, formerly known as ServiceLink. So we're transitioning how we identify with the work that we're doing at the Aging and Disability Resource Centers and transitioning the name. We also began to implement person-centered counseling within the Aging and Disability Resource Center contracts and hired the two full-time staff at the Bureau to oversee coordination and operationalizing the person-centered counseling services. We conducted a CFI rate study, a Choices for Independence waiver rate study, and we issued that at the end of June, at the end of fiscal year 24. And we incorporated the elements that are included within that rate study in terms of the fiscal impact and what our recommendations are and our prioritized needs for the budget for the agency request. We also began phase 1 of our Bureau name change. We've made efforts to change many of our documents and outward-facing communications related to the name change, with it finishing up with the budget request and elements that have to be changed there. And we also filed our application to amend our DHHS 1115 demonstration waiver to include presumptive eligibility for the Choices for Independence waiver program. That was submitted in the spring, and the status of that is that we are currently waiting for the Centers for Medicare and Medicaid to review that amendment, and we will engage with them once they start doing that. In terms of next steps, things that we're working on currently and will be finishing up before the end of the fiscal year, we are finalizing what's required as part of HB2 in the system of care, which is a system of care plan and vision. We are currently working with a vendor to develop the draft of that now and expect that to be done within the next 2 months. We are submitting a state plan amendment to procure Medicaid administrative claiming for Aging and Disability Resource Center activities, which will increase our federal dollars that can contribute to the work that is being done. We will complete all of our information technology enhancements. And part of the annual report includes some detail in terms of what those enhancements are and what to be expected. We will also be submitting a Choices for Independence waiver amendment, and we will start that process after the new year to do that. And as part of our 26-27 budget request, as part of DHHS, we are monitoring and providing education on the agency and prioritized needs that the Bureau submitted. And I welcome any questions.
Representative Weber.
Thank you, Mr. Chairman. Thank you for taking my question and welcome back.
I just had an overall question about the CMS waiver process, because if you submitted in the spring and are still waiting for an initial response, that seems a little dilatory on their parts. Is that how long it normally takes for a waiver? Because I thought that most of them went through quicker than that, and I'm just wondering.
I wasn't sure if Henry might have some more detail on that, but I think it depends on what the request is and the staff within CMS who are reviewing it and what they have in queue also to review.
Henry Lipman.
We've got too many mics on the right. And get over that.
Yeah.
This is an engineer's wisdom. Right?
You're welcome. You're welcome to any of those.
So I guess the answer is that we have a commitment that we're going to, we've submitted it. There's an extraordinary number of 1115 waivers being done. I'm going to be talking about what we got in place. We had to prioritize what could get approved back in July, and this one was one that they needed more time to work through because it's not one they usually give, versus the others were ones that we already had to be renewed and were, if you will, higher priorities for the administration to get in place. But I just met with last week with the head of the waiver group to make sure that we're still expecting it back in July. They told us it would probably be within calendar year 25 that we would see it, and that's I think we'll get it. And it's just they're just overrun at this moment in terms of all the things they're trying to do, plus with the change in administration. So, yep.
Would you accept a recess appointment equivalent?
I'd be happy to do it.
If I just may, Mr. Chairman, I just wanted to make it very clear that I was not implying that anybody in our department was at all dilatory. I just seemed an extraordinary amount of time for the federal government to respond. So thank you for the explanation. I get it.
You're most welcome. I think we've been treated pretty well as a state in terms of getting things done, like with the dental waivers that we needed, and they've tried to work with us, and sometimes they have to pay attention to other states too.
Oh, darn. Thank you.
I think.
Yes, Representative Edwards.
Thank you for that. And putting on the Division III hat for a little while, I love the kind of the conceptual visual information aspect of this, but it would be nice, and I know that you have tons of spreadsheets that Mr. White's going to show us, but it would be useful in January or February, whenever, I guess it's going to be February when we get together, to see something like this and to show us what kind of general fund impact that these slides have, and on this circle of life, where we're kind of spending money, just to take this nice conceptual outline and give it some life in terms of what kind of resources are being consumed in this. This could be just a little bit of resource, or it could be a ton of resource, and that's really going to be important going into this next budget cycle.
Definitely.
Yeah, and so I'm not asking for feedback now. No. I'm just telling you, I think this, let's see this again in the future, but associate some resources with it, please.
Representative Merchant, don't throw away your lawn signs. We want you back in 2 years.
Thank you, Mr. Chair. Thank you for this presentation as well. One of the things that we're experiencing here in the state is an aging population. And also, when I talk to people, there's more desire to stay at home, age in place, which is non-institutional care. So trying to tie this all together goes back to Representative Edwards, is looking for resources, because ultimately, if we have an aging population, when you build the budget, is we have enough resources into the home-based care that we put in institutional care, because if that's where people want to stay, I'd like to encourage us to do that. It's also less expensive. It is.
Representative Edwards.
I do have a supplemental thought. I think for the second year, I'm going to be wanting to take a look at if there are additional services that we want to migrate into a managed care structure. And so I think one of the conversations we could have in February would be, okay, this is sort of a roll your own state doing this for ourselves kind of thing. What would it look like if we were to try to put this into a managed care structure? So, and again, the resource implications of that. Thank you.
Any further questions? Thank you.
Thanks.
Great. All right. So as promised, up next we'll have Associate Commissioner Ann Landry and Medicaid Director Henry Lippman on community reentry, as well as the Medicaid to schools work.
Good morning. Ann Landry, Associate Commissioner.
Henry Lippman, for the record, Medicaid Director.
And we just wanted to take a few minutes this morning to share some exciting news as along the lines that the Medicaid team, along with behavioral health team and the Department of Corrections.
Excuse me, can I ask you to speak louder for these elderly ears?
Sure, sorry. My voice does stop. I'll be better.
Playground voice.
So for the past couple of years, we've had a dedicated team working on an exciting program that is focused on the re-entry into the community for the incarcerated population for the adults. And since July, due to a mandate from the federal government, we've also been working on a program to focus on reintegrating youth back into the community for those who are eligible 18 to 21 and then 21 to 26 from former foster care. And so this has really been an incredible joint effort between the Department of Health and Human Services and the Department of Corrections. And within the Department of Health and Human Services, it's been a close collaboration with the Division of Medicaid Services, Division of Behavioral Health Services, Division of Children, Youth, and Families, along with our eligibility team in Division of Economic Supports. So it really highlights the important work that we're doing together to ensure that these individuals receive Medicaid benefits pre-release and then back into the community. And with that, I'll turn it over to Henry.
Make sure you can hear me well. Yep. Okay, good. So I think probably those who serve in the House and oversee county are familiar with sort of the inmate exclusion, where counties have to pick up medical costs because, with only certain exceptions, they only cover inpatient care. This is actually a chance for both state corrections and for the county jails to be able to tap into some additional federal funding to support the successful transition from incarceration to the community. You know, the state and counties have done work with the Council of State Governments that, you know, one of the major reasons people have recidivism is difficulty maintaining sobriety or with mental health issues. So Commissioner Hanks approached us before there actually were criteria to apply for this grant and asked us if we would make a waiver request, a special request at the time, to obtain an 1115 waiver. And basically, we did apply in 2022. In 2023, the federal government came out with actually criteria to apply. We had to adjust what we had submitted. In July, we received that. So the net effect of it is that for adults, that during the 45 days prior to release, Medicaid can come in and provide support for mental health and SUD by starting to get the relationship and actually have managed care visits, if you will, like from the mental health center or others, to address those issues so that upon release, they've already have those relationships established. We can support some of the cost of those medications during that 45-day period. But probably one of the biggest savings and biggest success factors, I think, is that upon discharge, that the Medicaid program the federal government will kick in to pay for a 30-day supply of medications, so that, you know, when they they leave, they don't end up in emergency rooms or, seeking relief that they need to support either a mental health or SUD condition. So that's sort of the adult program. The idea also is to make sure that if they're eligible for Medicaid, to get that set up. So again, medical reasons, mental health reasons, pharmaceutical reasons aren't the reason for recidivism. And as I mentioned earlier, the Council of State Governments who studied a lot of New Hampshire's experience, and Commissioner Hank's own experiences, a lot of those recidivisms are related to health conditions. So that we were among the first states in the country to receive that waiver. We'll probably be second in the country to be implementing ours. We're looking to implement in January, starting January with the state facilities, because we've been working for a long time, as Associate Commissioner Landry mentioned. And, I think we're fortunate to have in Commissioner Hank someone who is, actively engaged in wanting to do this, and so that's helpful. So as Commissioner Landry mentioned,
Before you move on,
Sure.
can I ask a question about what you said so far?
Sure.
So the idea is when somebody is released, there's 30 days of medications supplied. Sorry. 30 days of medication supplied, and many presumably will not have a job to go to, or so they would qualify for at least Medicare, perhaps.
Medicaid.
Medicaid, okay.
Some will
Thank
qualify
you.
for Medicare if they're older, being released.
Got it. And that would mean that you got a 30-day window to get them into this, otherwise they can't afford their medications and.
Right. I mean, I think, if anybody just try to make a doctor's appointment today, or establishes a new patient, it's difficult. And so what we don't want people to do is fail on all the good work that's been invested. New Hampshire fulfills its constitutional responsibility for treatment within, the system. And so, you don't want all that good work and time and effort to then result in a bounce back because they haven't got the medicines and care that they need.
Representative Weber.
Thank you. And as a follow-up to that question, was I hearing that during the 45 days when they're still incarcerated, there's also an effort to make some community connections so that upon release, which is a big shock, they might actually have already formed a connection as to where to go to continue with whatever kind of services they're needing? Is
You
that
have
correct?
it correct. So the intake
That is terrific.
Yep. And hopefully, also there's a care management component which will be provided by the MCOs to make sure, like if they need appointments, that those are established before they hit the street, if you will. And we'll be coordinating with the care coordination that happens within the correction system.
Thank you very much.
Representative Edwards.
Thank you, Mr. Chair. So again, I'm just got my financial hat on. The adult community reentry demonstration looks like it was our idea, and it's a good one. But it's got a cost implication. I'm wondering if it's a net reduction on state costs, or if you think it's a net increase in state costs.
I believe there will be a net reduction. That reduction, like with dental, when we talked about
Right.
that, not going to happen immediately.
Okay, just interest of time. That's really all I needed to hear. And then, if I may, on the second one.
You may.
Same kind of question on the community reentry demonstration. This looks like an unfunded mandate that is going to cost us more money, and I'm not talking about the quality and value of the program. I'm just looking at increased demands on general funds. This feels like an increase in demand on general funds. If so, can you give me an idea, rough order of magnitude, what the price tag is?
So we're talking about youth reentry now, the
Yes.
congressionally mandated piece.
Yeah.
So it may relieve some costs at a county level. It may relieve some costs in corrections. And again, like most of when you think about children, kids coming on SYSC, we have them typically for
Just for time, I'm just talking about money.
Okay. I would say that net cost, again, over time will be less than what we're spending today.
Even though it's an unfunded federal mandate?
Well, the feds are putting money in as well, to cover costs. I think that since we have them in the program anyways, if we have them in a planned fashion and we're doing it on a preventative basis, we're gonna, dealing with people in emergency rooms, dealing with boarding and dealing with other issues that we deal with, I think the cost of the system as the state experience, it should be less than what it is today. And in terms of the next managed care contract amendment, we do have some costs that we pay out,
Right.
but I think that the costs that come back, that we don't experience in the back
Right.
end will offset that.
Thank you. This would be a good plan, A, B, C. This would be a good B or C conversation to have offline.
Sure.
Please continue.
So on the youth side, the benefit's a little bit different. And basically there's 30 days prior to release. There's basically the EPSDT, basically the screening for conditions and diagnostic services can be covered. And so like a physical or mental health assessment, all those types of things are coverable services. Plus, after release, whether they're on Medicaid or not, they get 30 days of care management. The other thing is that, in Medicaid, the definition of child is under 21. In the prison system, it can be, different. They might look at it as 18. The other thing is former foster care children up to they're under 26, if you will. When they turn 26, they lose it. But the former foster care, which nationally they say about 50% of the children that are in prison have had former foster care. So making sure that they're getting supports as well. Also in our managed care program, the general managed care program, when we get there, when we re-procured, we have prioritized managed care follow up on this priority population of incarcerated individuals, to follow them up for a year to make sure, again, that we're experiencing the cost at the lowest level by doing more things on a preventative basis.
Representative Merchant.
Thank you, Mr. Chair. It's more of a comment than a question. I think what I'm hearing is that this is more an investment than an expense. If we're investing in trying to help the individual get off on the right foot, the long-term payback could be tremendous. Is that what I'm understanding?
Yes, I think both for corrections and county jails in terms of recidivism, and in Medicaid, that we're dealing with the problem at the right level, not in the ER, not in institutions.
And what I'm trying to get
Follow up,
to,
yes.
if I may, is in Sullivan County, we actually have something called the Sullivan House. Because what we found out is that when you go through all the investments, whether they're incarcerated, and to get them on the right foot, they end up going back into the apartment which they came out of. So we actually created the Sullivan House in order to help them for another 6 months. So expect maybe this, again, if it's pilot, is collecting some data from the Sullivan House to show what it will mean as far as that investment.
If I could make one comment,
Yes.
and I think I can end it at this if you don't have any other questions, is that we're already starting to meet with counties. We've met with Sullivan County. We've met with 6 of the 10 so far, and we hope in the next few weeks we'll accomplish the rest to make an assessment. One of the things, the differentiating factors here they'll point out that's in the presentation is that the federal requirement and the waiver all are on people who are sentenced or adjudicated. So if you're not sentenced, which in the counties can be up to 75% of the population or more, they're not eligible for the benefit. And so we have to work with the counties to make sure that the system to provide the medical services fits with what they're already doing.
May I make a suggestion to you and to anybody else listening? There are a certain number of people that I only can convince, not on the basis of whether it's right or compassionate, but that it is saving money. And I can intuit that good things often save money. They are truly investments. But some people need to see numbers. And whether it is something at a beginning stage here, or you make use of this being implemented in other states, so there is a longitudinal study, those numbers help me sell the product.
We do have a requirement under the 1115 waiver to do a formal independent evaluation of it. So there'll be an interim evaluation and an evaluation after the 5-year waiver length, and we intend to do evaluation on the federally required program
Good,
as well.
good. Looking
Bring
forward to
that
seeing it.
information to you.
Thank you. Any further questions? No, thank you.
Oh, Medicaid to schools, I think was the other.
That's right. Well, do you want to ask if they?
Would you like to hear that today, or do you want to do that?
Can I have a 3.5-minute version?
Yes, maybe even less. So, thank you. I'm on the clock. I think Representative Edwards brought up a concern around parental knowledge of what's going on. And I'll differentiate what's going on in the Medicaid to schools, which may happen in schools but not related to the Medicaid to schools program. The Medicaid to schools program, the parent has to sign off on the plan of care and changes in the plan of care. Also, in the Medicaid program, the parent is what we call the case head. The case head is entitled to get any we have to provide the full, if they ask for all their billing information to see what's going on with their child, they have a right to access that. And so I think we talked a little bit about this at fiscal. I don't know if we need more on that or not, so I'll leave it up to you.
Okay, so I appreciate that. I understand that. I'm still concerned a little bit about this edge case where kids age out while still in school to where they accrue a privacy right they didn't when they were younger. Is there a group, a demographic in this Medicaid for School program in which their adult medical privacy rights kick in and the parents are no longer in the loop about what's happening to their care?
So, as I understand, the case head has full access to the records that the billing information and what have you. So, I think that the protections under the Medicaid to School program for parent wanting to know what's going on are covered in several different levels. They have to do the approval initially of the plan. Schools don't want to, because schools have to pay money to have Medicaid to schools. They have to pay half the cost, and so their schools are not interested in picking up extra costs through that mechanism. And then if there's a change in it, there's a required sign off, and to bill Medicaid, the parent has to sign off on. That's not to say a bad actor, if you will, might do something that isn't right, but the program, I think, is structured to protect parental rights.
Okay, let's move on.
So my editorial comment on that, other than thanking you for following up, is that I think it's critical in this environment that the transparency with the providers and the parents is maintained at a very high level in order for there to be faith and credibility in this program and therefore sustainability, and without it becoming a political distraction. So I am glad to hear what your description, and I just hope we continue that.
One final comment. There's been in the media this past week about local communities struggling and the state struggling with special education costs. The medical component of that, one of our goals, and we talk about this at another meeting because I want to stay within my 3 minutes, there is help available through Medicaid to communities in dealing with some of their special ed costs. And I think we need to work with them and we have a plan to do that, but I know we don't have time to talk to you about it.
Good, thank you. And not counting Representative Edwards' comments, I owe you 22 seconds next time you're here. Thank you.
Thank you for the great questions and for inviting such an array of updates. If you want, I can maybe do the 20-second on the two reports that you asked for feedback on. But I guess what I would just say at a high level, something that struck me listening to my colleagues is that everything you're hearing about today as part of our commissioner's update, or our deputy commissioner's update today, is part of our DHHS roadmap that Commissioner Weaver presented to you all. And it's about serving people in their communities and not in institutional settings. And to that end, I want to just emphasize there are two quarterly reports that you have. One, I believe you have in print here today. The other one, John Williams is going to help me distribute via email momentarily. And I just want to give the 10 seconds on each of them. So one is the quarterly report on HB 49, which is the bill to replace the Sununu Youth Services Center. And the big news there that is in that report that you have is that we have officially begun construction of the new facility that will be located on the campus that is shared with Hampstead Hospital. We are continuing to engage extensively to get community input, stakeholder input, and make sure that this is in line with the expectations of HB 49, as well as the important concerns that have come forward from local neighbors, behavioral health advocates, et cetera. So happy to answer any questions. The other report that you have is on the quarterly report around HB 1573, which was sponsored by our own chairman, Representative Pearson, and is a bill to allow the department to continue its work to strengthen oversight of youth residential programs, and to ensure that in those increasingly rare times that we need to utilize programs, especially those that are further from New Hampshire, that we are doing so with a commitment to quality and to short-term placement to ensure that kids are getting back to their homes and communities with as many supports and as promising a future as possible. So really proud of our team and the progress that they're making on both fronts, building a residential, architecturally secure, therapeutically oriented facility for our juvenile justice population that requires detention or commitment, and also strengthening our oversight of the residential treatment facilities on which we will continue to rely less and less as we come up with community alternatives. Probably more like 1 minute and 40 seconds, but
Actually, it's 1 minute and 23 seconds.
yeah.
But who's counting?
Any questions before we give you back the agenda?
We're
Okay.
good. Thank you.
Thanks.
Next item.
Good morning, Mr. Chairman. I didn't mean to be presumptuous in just coming up, but
No, you were covering for me because I was trying to find my place and I just outed myself, but thank you.
we'll keep you on track, Mr. Chairman. No worries. For the record, DJ Betancourt, Commissioner of the New Hampshire Insurance Department.
Kirk Williamson, the Executive Director of the Prescription Drug Affordability Board.
So we are pleased to join you this morning to discuss the Redundancy Elimination Report. I would note at the outset that, unfortunately, I do apologize that our resident, and I say this with the utmost admiration and kindness, our resident data geek, Dr. Jason Azes, who is the director of our data analytics unit, unfortunately is away today. So you're stuck with me. I will highlight what I think are the pertinent aspects of this report in the best manner in which I understand it.
Do we have a handout of some sort? What does it look like? Oh, coincidentally, yes. All right. Got it.
Wonderful. So as I was saying, I will do my best to hit what I think are the highlights in the best manner possible, which is to say to the extent that I understand all of this. And if Dr. Azes doesn't like it, well, don't go on vacation next time when we're supposed to be here. And then obviously I'll turn it over.
You can declare him redundant.
Certainly not. I'm more likely to be found redundant than him. But in any event, this report came about as a result of a legislative request, which is to say you all put it in statute, which required us to do it. And so Dr. Azes and his team really did throw themselves into this work. Dr. Azes had the benefit of also serving as a member of PDAB, and so he was able to bring that background and that experience to bear in putting this together. So at its root, the purpose of this report was to identify and describe relevant oversight and or regulatory redundancies with regard to the collection, analysis, and reporting on prescription drug prices among the Department of Insurance and the New Hampshire PDAB Board. I'm pleased to say that to my reading and my understanding, what you see reflected in this report is about 80% consensus between the department and the PDAB board. There are some areas of diverging views, and that's perfectly fine. At the end of the day, when it comes to this report, I take the same attitude that I take anytime I appear before a legislative body, which is to say, we have put forward what we think is good work. We have put forward what we think are solid recommendations. At the end of the day, it is up to you as the legislature, as the policymakers, to decide what you do and do not want to consider and or move forward with. But this is the information that we've put before you. Do with that what you will. And so again, some of the highlights, the first focus was on data collection, and you cannot have that particular conversation without first acknowledging the fact that the department has access, as does the Department of Health and Human Services, to an incredibly valuable tool, the All Claims Database, which is abbreviated to CHIS. So as I've said, DHHS has access to this. PDAB, as the result of living kind of under the Department of Health and Human Services, also has access to that data, the data that they may desire via the CHIS system, via the Department of Health and Human Services. And so the report, as you'll see, does not see a reason for PDAB to have to collect data. Now, I will tell you philosophically that the collection of data on the one hand is unbelievably important. But there's a limit to that data in the sense that you can drown yourself in it. And so what you want to ensure that you're doing is that you are collecting data that is getting you towards some sort of a policy objective. So that's in the first instance. In the second instance, you want to ensure that the individuals who are taking in and analyzing that data have the ability to understand it. Otherwise, you're just getting numbers in. You don't know what it's driving you towards. In the best instance, in the worst instance, you don't understand it and therefore run the risk of having it be something that you make a decision on or begin to formulate thoughts around when you don't actually understand it. So again, the report would suggest that PDAB would have a very, very difficult time if it attempted to try to get into the data collection business. Again, under that headline, we would point out the health cost tool. We always talk about that. It's a great asset to consumers as well as to policymakers. And again, that's a similar resource that should provide PDAB with the data that it's looking for. So again, I understand that there are some who feel that PDAB should have access to raw data rather than the data that they would get via the insurance department or the Department of Health and Human Services. Again, that is a decision for you and the legislature to make as to whether or not you want to give them that access. Again, I would highlight two issues. The first is, again, that comprehension piece, how to best understand and interpret the raw data that you're getting. That may very well be surmountable, depending on the experience of the individual members making up PDAB. But you also have a pretty significant legal consideration to think through, which is a lot of the raw data that exists within these systems is proprietary data. And so who has access to that data is very, very carefully considered. And we'll get to that in a little bit. So the second big piece of the report surrounds PBM reporting. And I will admit that prior to the passage of Senate Bill 555 earlier this year, the department, quite frankly, did not have the tools that we needed to be able to get information that was useful not only to all of you as policymakers, but useful to us as a department. I was stunned when the first reporting requirement under the previous statute came up, and legislators were asking me for the reports, others were asking me for the reports, and I said, I need to see these reports. And what I would get back are these 1 or 2 page attestations that told me absolutely nothing, and therefore were not going to be at all helpful to you. And Senate Bill 555 thankfully gave us the regulatory teeth that we need to get the information from the PBMs that is going to be useful to us and ultimately useful to all of you as well. But as a consequence of that, Senate Bill 555 did create some redundancies that were not anticipated prior to the final version of Senate Bill 555 being finalized in either June or July. I can't quite recall. Again, I would highlight at this point, and this I think is pertinent not only to this report, but I think to the discussion of PDAB and prescription drug data collection writ large. Believe you me, I am very frustrated sometimes in this position by the information that I am and am not legally permitted to disclose. And when you are talking about PBM-related items, there is a lot of protection for proprietary information. And the consequence of disclosing any of that proprietary information is that I, or any individual who would disclose it, becomes personally liable under the law to suffer the potential consequences of disclosing information that I'm not. And I can assure you that the Betancourt family budget does not have the capacity to defend any sort of a prosecution or lawsuit coming from a PBM or otherwise. And I appreciate the fact that this generates a lot of frustration for the legislature, a lot of frustration for PDAB. We do the very best we can to be as transparent and forthcoming with the aggregated data that we are permitted to make available. And so again, I think those proprietary and privacy protections are a very pertinent issue that again crops up not only in terms of this report, but again, as it pertains to PDAB as a whole. The next item I would highlight is the drug manufacturer price reporting. The issue there centers around the fact that both PDAB and the insurance department have the authority to collect this data. The question is a matter of who is going to do this work and who is more, or I should say, who is better positioned to do this work. So the department right now has the experience, we have the staff, we have the resources to do it. If you wanted PDAB to do it, that again is your decision, and we'll abide by whatever you decide, but it would require a lot of staff and a lot of resources. PDAB would have to, I would think, bring on quite a few people to come help. And so, again, the redundancy there is we both have the authority. That's not a question. The question is who is better positioned and who would you prefer to do that work. So the last piece of that I would also mention is that we are currently required to report this data to the Board of Pharmacy. So if you decide ultimately that you wanted PDAB to do this work, don't forget to have them take on the responsibility of reporting it over to the Board of Pharmacy and taking it away from us. So I think I've gone on quite long enough, and I'll turn it over to my colleague here, who is much smarter than I am on all of this. So you can ask him all the tough questions, and you can save the easy ones for me. Thank you, Mr. Chairman.
No. Thank you all for having me here. I do want to say we really appreciate as a board being able to collaborate with the insurance department. I think that was key in getting this report across the finish line. And collaboration is crucial, particularly with such a nuanced and complex issue of such an opaque nature as prescription drug prices. Oh, and I can remind you for the record, I'm Kirk Williamson. I'm the executive director of the Prescription Drug Affordability Board. I'll say that the report did serve as an important moment of reflection. I think it allowed us to systematically look across the state and see where we are collecting data, where different data is housed, whether it's in the APCD, whether it's contained in the insurance department, and whether the PDAB has the existing authority or MOUs in place to access that data to fulfill its mission. The board did vote this year as part of its goals for 2025 to execute an MOU with the insurance department so that we can eliminate any redundancies and leverage everybody's shared work. Of course, there are protections that would need to be built in place, particularly if we are accessing net price data or anything around rebates. And I would say that, because this is such a complex issue, that we are interested in working with all agencies. We have an MOU in place with HHS so that we can access CHIS data. We have a goal to execute one with the insurance department, which again shows our collaborative nature to tackling this issue for Granite Staters. I think it's also important to remind the members that the insurance department and the PDAB play distinct but complementary roles in addressing prescription drug affordability. And I think our ability to meet, we met last week to discuss a lot of these issues. And I think that through the MOU, we're able to eliminate any possible redundancies and continue this work with vigor. I'll pause there. I know we've been speaking for a while, so I'm happy to answer any questions.
Representative Merchant.
Thank you, Mr. Chair, and also thank you to both of you being here today. I'm just for the record, I am also the chair of the Prescription Drug Affordability Board, so I want to be clear about where I'm coming from. One of the things we talked about before, I think Commissioner Betancourt, you talked about this, is data collection. When I was at Mary Hitchcock, we started out with every department, a lot of departments collecting data. What we migrated to was a data warehouse, so that we had an entity within the organization that knew how to collect data. So the departments would then work with them to what data they needed to have. And then the data warehouse would collect the data on their behalf. Is there somewhere in the state of New Hampshire, are we working towards a comparable data warehouse? Because I do agree that collecting data and how you go about doing it, the process itself can be onerous and it has to be done correctly. But have redundancy, again, if we're having different agencies collecting data, are we not by default creating redundancy in the data collection versus having a central data warehouse in the state of New Hampshire?
Well, I think a lot of that depends on which agency has the authority to collect which data and which data falls underneath the mission statement of the particular agency. So obviously the focus of the insurance department is different than, say, the mission of the Department of Health and Human Services. We have access to different data, we have different focuses, but I agree with you, to have it in one centralized location is incredibly beneficial and, dare I say, efficient. And I think that ultimately that's the vision that we all have for the All Claims database, the CHIS database system. And we take it very, very seriously. We want that to be an incredibly useful and powerful tool for not only the agencies to leverage, but ultimately for all of you to be able to leverage as well. And it's the reason why when the insurance department did a recent reorganization of our operations, we created a separate data analytics unit. And part of their mission is to look at how we can enhance the All Claims database system, including how we can enhance it to collect information around PBMs and prescription drugs. So designating one agency to be the sole agency that oversees and plugs data into CHIS, I think would be problematic for the reasons I've described. But having that one system, I think that's very beneficial.
Follow up.
Thanks. Thank you for that, Commissioner. So I want to be clear, you're not saying that the board should not have authority to collect data, but you're talking about trying to find a way to collect the data on behalf of the board.
So I think the question becomes, what do you have the capacity to take on? And if you're going to take on trying to collect data, I think you need to ensure that that data is not already being collected by either the insurance department or the Department of Health and Human Services? And then how do you navigate the fact that you're going to need to bring to bear a level of expertise to be able to understand the data that's in front of you? And what legal protections are you going to put in place should the data that you're attempting to collect be considered proprietary? I think those are tricky issues to kind of work through, particularly when you have resources like the expertise you see in the insurance department and the Department of Health and Human Services.
Representative Edwards.
All right, so we have you surrounded. We have the chair of the PDAB here. I'm a sitting member of the PDAB, and I think I have another 4 years in my term for that. So I've been involved in this redundancy report since its inception. I appreciate all the work. I have worked with Dr. Aziz. He's a great gentleman, very smart, too smart sometimes. But so just I want to summarize, break it down to a simple level. The result of the redundancy report is that there has been identified some redundancies in the way the PDAB was initially legislated and what the insurance department and probably other departments of the state are doing. So yes, there are redundancies. Two, I think some of the redundancies are significant and need to be addressed, and that this summary basically creates a list of the significant ones but it's not inclusive of all redundancies. This is a summary of the significant ones, I believe. Is that true?
That's correct. We wanted to ensure that, I mean, the report at this point is already at 9 pages. We wanted to provide you with the ones that we felt were most obvious.
So thank you. So knowing that this was coming on, a few of us legislators have been getting together to try to draft a couple of bills, as it turns out, to anticipate the trajectory of this redundancy report and to pick up on it and try to address some of those redundancies in law. Specifically, who's going to collect and store the data and protect the data. That's something that proposed legislation is going to include. And so those bills are not ready yet to distribute more widely, but I would love to be able to send you, and of course, Mr. Williams, you'll just get it automatically, but to you, Mr. Commissioner, our proposed legislation, so that if I'm missing something as the prime sponsor, that you shake and let me know.
Certainly, we're happy to do that. We do that for legislators all the time. And I would say, philosophically, I think we're all in favor of more efficiency in government.
Right.
I don't think that's a controversial position to take. But in terms of the policy decisions, those are yours to make. But what I would tell you, Representative Edwards, is if you say this is our goal, and this is the language that we think gets us to our goal, myself and the experts within the department will look to make sure that those two things are in alignment.
Yeah, and I appreciate the follow-up. Thanks, and I just do appreciate the statement that was made that in the last week you've had discussions about the redundancies and how to ensure the PDAB and the other work done by the insurance company, the department, and others are complementary and not overlapping. And so that's really been the objective of asking for this redundancy report. So thank you for helping us nail the landing, I hope.
Any further questions? We're running behind our schedule, so please make them succinct if you have them. Ditto with the answer. Thank you so much for your report.
Thank you, members of the committee.
Medicaid reimbursement rates for prosthetic and orthotic devices update report, Mr. Henry Lipman and Mr. Henry Lipman. And you have all the time you need, plus about 22 seconds more, but be brief. And turn on your mic. Thank you.
Very good. So the report I provided, I gave you paragraph by paragraph what's in the law and how we complied with it. We have complied. I'm happy to take any questions. The fee schedule update is attached to the report. I think it was just to make sure that we did what we were supposed to do, and I can report that we did.
So do you want to take over as vice chair? Well,
Sure. Yeah. Representative Edwards.
This is a question for Representative Weber, actually. Do you recall who wanted this report, and if you think it meets the requirements of the person asking for it? I don't recall.
I don't, so I don't. I'm sorry about that. I remember that we had the discussion, but, and I'm glad to have the information. I'm trying to recall whether it was in the context of a bill that we had in front of us at Health and Human Services, and I think that that's probably the genesis of it. But I'm very sorry, right at the moment, I'm not remembering. Perhaps Director Lippman remembers. But
What I remember how the 90% came about and how it was Representative Houle, if I'm pronouncing his name correctly, suggested that the 90% be tied to the January 2024 rate for Medicare at the time. And that's how I think it probably came about,
Okay.
that confirming that that's what we did, and the details here to support that.
thank you.
Any further questions? No? Seeing none, thank you.
Welcome.
Yes, public awareness campaign on brain health, Alzheimer's disease related dementias. Now, this is from the, which group?
The Bureau of Adult and Aging Services.
Okay.
Let me see, I'll just show you the handout. We have the annual report for the public awareness campaign, and then we do have a slide deck with brain health campaign activities listed at the front that you should all have. Again, Wendy Altman, the Bureau Chief for the Bureau of Adult and Aging Services, and I have here a partner, Jennifer Horgan. I'll let her introduce herself.
Thank you. Jenny Horgan, Senior Public Policy Director for the Alzheimer's Association.
And we sprung you out of the Senate.
You sure did. Yeah.
So in front of you today is information just to give you a progress update on the brain health campaign and what we've been able to accomplish over this last year. What I'd like to focus on is the brain health campaign activities. We have been, since our last update in front of the committee, we were able to make progress on a pre-campaign survey, and we were able to review those results. We also engaged in developing an ambassador committee, which really is made up of individuals who are either living with some form of Alzheimer's disease or related dementia, or family members, really to give feedback on campaign work, as well as members of the subcommittee for Alzheimer's disease and related dementia. They will be involved in helping with the media campaign materials and work. So if you were to look at the slide deck, we are able to provide you with some of the activities that we're currently working on and the timeline for all of those activities over the next couple of months. So we will be creating a campaign webpage that will be part of the DHHS website. We will create a public campaign material portfolio, which includes radio, TV, and print, digital and social media ads, as well as a series of health professional materials that will be digital, social, and video, as well as brochure. We included in the slide deck a sample of what some of those materials look like based on the work that we've done with our work group, which includes the Commission on Aging, members of our communications office at the department, as well as subcommittee members and other partners within the community. This is an example of print communication materials, which is a brochure to promote brain health And we also then on the next page have the media ads and the general public campaign that will be taking place, and the timeline in which that will happen over the next couple of months within the state fiscal year, and the reach in terms of the impressions and views that we expect to get from this campaign. The toolkit that we will be creating for our strategic partners will also be developed, and there will be a plan for dissemination and outreach to community partners, including senior centers, libraries, area agencies, and medical facilities and others. We do expect at the end of the campaign to have a final report on the media work and the partner and outreach achievements that we were able to see, as well as a post-campaign survey. We will compare our pre-survey work with individuals and conduct a post-campaign survey to gauge performance in terms of level of knowledge, awareness, and intent to look at the success of the campaign. And I'm happy to answer any questions people have, and happy to catch the agenda up if there aren't any questions.
Any questions? Looking around, Representative Edwards.
Thank you, Mr. Chair. I think I have two. One is, was this the funds to set this up? I seem to recall it being positioned as one-time money, and I don't remember if it was federal ARP money or something, but was this in the budget as a one-time investment, or is it ongoing?
Currently, this campaign and the work that we're doing to operationalize it was funded through HB2, and it's 100% general funds.
Yeah.
And it was in the amount of $500,000.
500,000? Okay, let's follow up.
Follow up.
And I think at the time that we were doing this, and this may be for Dr. Henn, is that we made the observation that this program was going to get set up under your department, and that we tried to encourage that you work with the public health people who had a similar public-facing mission, and that in this next budget cycle that we were looking at one public-facing advertising marketing group in DHHS and not proliferate in multiple departments. Or where are we at with making sure that we're aligned and we're pinning the rose on one entity?
I'll start, and then if Marissa has anything to add, she can add. Many of the materials that we're looking to produce can be reproduced and be done on an ongoing basis. Because it is brain health, we do expect that we'll have some coordination and collaboration with public health in terms of any resources or funding that we can collaborate on between both our bureau and population health within DPH.
Okay. So what I think I just heard you say is that you'll continue to remain the subject matter experts to update the materials, but that the people who are responsible for coordinating the contracting and development and distribution and website for the materials is going to be public health.
I would expect that it would be a partnership between.
No, I'm looking for roles and responsibilities, not partners. But thank you. I think I got it.
Any other questions? Thank you for coming. Thank you for your report. And Jessica Gorton, Director, DLTSS, Bureau of Developmental Services.
Good morning. Jessica Gorton, Bureau Chief for the Bureau of Developmental Services. So I am here today to give you all an update on our Q4 wait list. You should have a report in front of you. Unfortunately, mine is in color, yours is in black and white, but it does have the DLTSS and the DHHS logo at the top. It should be titled Developmental Disabilities, Acquired Brain Disorder. Yes. That is the one. Okay. So as we come again and report out to this committee, we still continue to have no funding wait list, but as this committee has expressed an interest, as well as the Bureau of Developmental Services, we really want to try to focus on who is actually getting those services that have been funded. What are the reasons that they might not be? Are they getting full services, partial services? And we really continue to hone our data. As some of you may recall, last year, the New Hampshire LEAD system that we utilized in partnership with our area agencies was sunset necessarily due to some system issues, and we transitioned to a state-operated system, New Hampshire Easy, or sometimes you'll hear it referred to as New Heights. This is where the information is now logged, stored, and we are starting to get I'm proud to say we are starting to get additional and helpful data to start to isolate and target initiatives and give us information on where we can best align resources and focus efforts in getting people access to their services. Also, on June 28th or July 1st, right in that time period, we rolled out a couple of pretty significant IT enhancements that we had mentioned the last time we came and presented. One was a provider view and access to our New Hampshire Easy portal so that they could see the status of those authorizations for services, those that requirement that allows them to bill and be paid for services rendered. In addition, we've automated the start dates as well in capturing that data, so it's no longer a manual process. So based on that service authorization, once that's entered, the start date is also now logged so that we can start to get more timely data, more point-in-time data rather, on when services begin. Also, working in partnership with our area agency staff, the entry of these delay reasons. We've presented and discussed in previous committee meetings that this was a manual process. And given the amount of work and the effort that everyone in our service system was putting forth in prioritizing those payments for services to get individuals faster access to services, we delayed the manual entry of those delay reasons, but as of July 1st, we've started working and entering that data, and it is starting to come in so that we can now include that information on the report that you have in front of you. So with that said, I'll dive into the report data if that's okay. All right. So for our developmental disabilities waiver, which is our largest waiver, we in Q4 had 100 individuals who requested to start services. 9 individuals withdrew their request, which can happen sometimes. So of those 91 remaining individuals, 86 were projected to start their services within the quarter. Of those 86, 25 began their services. And the remaining 61 that did not start their services had delay reasons that are laid out within the report. The top 3 being they're in trying to secure a provider agency, find a provider who is able to offer those services in the way the individual was looking for them. Individual and family request, I will say, given the quarter being Q4, because a lot of the folks who are newly requesting services are transitioning out of school, it's not uncommon to see a request to delay services until maybe after the summer. And then the other reason is folks attempting to access the Medicaid benefit, going through the application process and making sure everything gets put through. Looking at our in-home support waiver for children and young adults who are still in the school district and accessing services within their family home, there were 10 folks who requested funding and who were funded. Of those, 9 began their services, and 1 individual did not start services due to an individual and family request. And on our acquired brain disorder waiver, 1 individual requested requested funding, and we did fund that individual. They were pending their Medicaid benefit to begin, so they had not started services within the quarter. So as you know, we've discussed us really looking at how do we get in there. The top reason really does remain, as it's reported both anecdotally from family service coordinators and as our data is starting to show, we're continuing to struggle in the area of workforce. So the department has put forward a number of workforce grants totaling over $15 million, as well as over $7 million to service coordinators or case managers in our service delivery system to try to infuse some funding into efforts around workforce retention and recruitment. Our service coordination agencies and the Bureau have focused efforts on ensuring service authorizations were in place. This is a reason that in past meetings we have reported was also impacting delay, and we're really proud to say that through partnership and work with our area agencies, our service coordination agencies, and the Bureau, as of the writing of this report, only 3 service authorizations were over 14 days and waiting for the Bureau to have an initial review of that. So the data is starting to really help both in getting folks access to services, but also in our ability to prioritize and organize workload so that we have that view on what's coming in and make sure that we're getting that work done as quickly as possible on the Bureau side as well. We continue to facilitate ongoing meetings with our service coordination agencies, our provider agencies, and now our intake coordinators at our area agencies so that we can all exchange information, talk about workflow, talk about the data and what enhancements might be needed within the IT system. It's been a great process in moving into this data in this database. And as we get data, it shows us what we would also like to see, different ways to slice and dice and put those requests in and try to find additional opportunity for us to just efficiently view and organize the workload.
Representative Edwards.
Thank you. I think this may be the most spectacular thing I've seen coming out of the state in all of 2024, because we had been asking for the real wait list information for, 3 years now, something like that. And so you've accomplished something that is just wonderful to know that, and it isn't just that you've gotten it done. It feels like you have pretty strong data confidence, that you know the data is real, and that you've developed a work plan on how to continue to improve it. So that's all excellent. I would just recommend you include a point of contact in the report to take credit for all the good work and to get the occasional attaboy and supplemental question. But seriously, thank you. 3 years of asking for this.
I would also want to say thank you because earlier in my time in the House, I had been quite active working with a couple of area agencies and so on. And there was this frustration on the part of individual citizens that they weren't being heard. They didn't have a chance. I don't hear that much. I mean, there's always going to be some people who say that, but I find it's in a manageable amount now compared. So again, thank you. And what's your contact information? Because it's not in my phone.
I will
So
bring
therefore
some
it doesn't
business cards
exist.
up shortly.
What's that?
I can bring some business cards up
Oh,
shortly.
cards
and
are
have them
great.
with me.
Yeah, I love cards. Thank you. Any other questions? Yes, Representative Weber.
So now that we have all this great data, and I add my thanks to everybody else's, I'm wondering if you could elaborate a little bit on the No Current Medicaid Open category, because that seems to be one of the roadblocks. And is that a matter of people needing help to finish the application process? Or are there things that you see that we could be doing to facilitate getting that category down? Because I understand the other ones. Sometimes if the people aren't there, they aren't there. But
Yeah, it could be for a number of reasons. Folks sometimes will apply and maybe not offer the verifications or the documents that the Medicaid office needs to determine if that individual might be eligible, particularly around the look back requirement, if folks have heard that terminology and looking at those assets over the last several years. In some cases, folks maybe need some support in filing those applications. And we've been able to create really strong collaboration and partnership with our Bureau of Family Assistance and also with the ServiceLink Aging and Disability Resource Centers, overseen by my colleague Wendy, in making sure that folks have access to those supports too, if they need just a little extra, some arms wrapped around them and the application process to help them navigate that and what can often be a very trying point in time in their life. So we understand more supports are needed. Those are typically the reasons that we see that delay. Thank you. You're welcome.
Thank you very much for that.
Any further questions? Thank you, Ms. Gordon. Appreciate
Thank you so
your
much. Take care.
Now, a report update regarding the use of restraint and the use of different modes of transportation of patients to New Hampshire Hospital or other designated receiving facilities. And in the matter of full disclosure, my younger son, Michael Pearson, is a corrections officer at a full maximum security place in New York State and does a lot of prisoner transport. So this is a subject I'm kind of interested in. It will come up over the Thanksgiving table. Yes.
Good morning. I'm Cynthia Babonis. I'm the Chief of Community Integration at New Hampshire Hospital.
And good morning. My name is Caroline Lavoie. I'm the VP of Data Analytics at the New Hampshire Hospital Association. And can you hear me okay? I know I'm soft-spoken.
It can get better.
It can get better. Is
It's
that better?
good, but that's better.
All right.
Closer to the microphone.
Okay. Thank you.
Playground voice.
Well, good morning. Thank you for having us. Before I dive into the report in front of you, which is titled the New Hampshire Patient Transport and Restraint Data, I do want to give just a brief bit of background on why we are here talking about this report today. So any patient in New Hampshire who is designated involuntary emergency admission, or IEA, must be transported from the emergency room, which they are seen, to either New Hampshire Hospital or one of the other 6 designated receiving facilities throughout the state. There they will get the appropriate inpatient psychiatric treatment that they need. Historically, before 2020, all these transports were done by law enforcement, but Senate Bill 177 gave the explicit option of using an ambulance in addition to the option of law enforcement. And the idea there was to reduce the use of restraints in these transports and the associated trauma with that, while keeping the safety of everyone involved at top of mind. So now a provider who designates an IEA gets to choose whether law enforcement or ambulance is appropriate, and then the transport agency themselves ultimately gets to decide if restraint usage is appropriate in that case. So this is now the 5th report that we are presenting to this committee. The law also said that all the DRFs had to report on a yearly basis their data to this committee. That included the number of transports broken down by age, type of transport, and restraint usage. None of the DRFs reported data before 2020, so we don't have anything to compare to before the law went into effect. So, like I said, this is the year 5 report, and this represents October 2023, to September 2024. The top of page 1, you can see there is a bit more background information on the law, as well as a stakeholder group that came together to give input to this process. At the bottom, we see some summary statistics for the year. So we had 1,251 IEAs. That's an average of 104 per month. 99% were adults. There were only 4 child transports for this year. 40% of transports went by ambulance, 59% by law enforcement, and the remaining few is an other category, and that's almost always a family member or facility staff member transporting the patient. A little less than half of transports occurred without restraints. There are a handful of unknowns. And the breakdown of type of restraints used, the majority were either waist belt or a combination. Top of page 2, you can see all the transports broken down by DRF and by month, just to give you a sense of volume. The following sections give a summary on the mode of transportation, restraints used, usage, and the type of restraints used, but you can see more detail in the appendix if you are interested. So for mode of transportation, again, since 99% were adults, and this is for adults only, we're seeing the same breakdown of 40% ambulance, roughly 60% law enforcement, but there is some variation from month to month throughout the year. Restraint application really depends heavily on the type of mode of transportation you're in. So 86% of law enforcement transports used restraints, were compared to ambulance. There were only 2 cases of restraints used throughout the entire year. And on page 4, you see the visualization of the types of restraints used. Again, no one is overwhelmingly used, but the waist belt and the combination were the most heavily favored. For child transports, again, there were only 4 the whole year, 3 by ambulance, 1 by law enforcement, with no restraints used in any of the cases. On page 5 and 6 have provided some trending data for you to see how different metrics have progressed over the year. Over the years, we're really not seeing a lot of variation. We did see a slight increase in the number of transports in year 5, partly due to the fact all New Hampshire hospitals hard work. They were able to open the 12 additional beds back in April of this year.
Okay.
And the last page, again, a couple of visualizations to show you the trends over the year of all IEAs by month, and then restraint usage between ambulance and law enforcement transports over the 5 years as well. And then the appendix follows that. So I know I just threw a lot of numbers at you. Happy to take any questions on this data.
Representative Edwards.
Thank you, Mr. Chair. Really nice report. I on page 3, in the second line, it says that the restraint application that's going to tell, this report will tell us whether the application was before or during transfer. And then when I look at the key, I can see the before transport, but not sort of the during transport. I see start only. I don't know if that's meant to be the indicator for restraints added during transport.
Thank you for that question. Yes, let me clarify. So before transport, that's the vast majority. That means restraints were applied to the patient before and then remain the whole time.
Right.
There was one case of restraints applied at the beginning and then apparently removed during transport, which is an option that they had. That was what was reported to me.
Right. Yes, please. I'm just pointing out that the narrative says or during transfer, and there's no legend that tells us if it was done during transport. There's a conflict between the words and the legend is what I'm trying to say.
Thank you.
Inartfully. And then follow up. And then I'm looking at the graph on page 6, bottom right.
Yep.
It looks like this data is from 2020 to 2024. And as I look at the relationship between restraint used and transport, yes or no, it feels at first glance that it's in conflict with the data on page 3. Because page 3 seems to indicate that we have a tremendous amount of no restraint when you count the ambulances, and that this chart doesn't seem to reflect the ambulance lack of restraint.
Right. So on the left, on the bottom of page 6 is the ambulance. So it's showing almost 100%.
Oh, okay.
Is not using it.
That's my fault. I was looking for a blended graph, and you didn't put one there. So thank you for the clarification.
You're welcome.
Thank you.
Representative Merchant.
I'll make it quick. Thank you, Mr. Chair. In regards to the discrepancy or the variance, I should say, between law enforcement restraints versus the ambulance, can you speak to what is driving that? Is it because of the nature of the person being transported? Is it because of the philosophical or the way somebody approaches transportation? In other words, is law enforcement more likely to use restraints because it's kind of the way their DNA is structured? Or is it more because of the way the person who's inside of the law enforcement transportation is regarding it? Trying to understand which is driving it.
I can't speak with certainty on what's driving it, but as a clinician and someone who works at New Hampshire Hospital, the emergency rooms decide whether they're going to call an ambulance or the sheriff's department, and clinicians are going to lean into calling law enforcement for a more acute and potentially violent person to begin with. And so, I mean, there could be also some bias in law enforcement to tend to want to always use restraints, but it's already skewed by the fact that the emergency room has decided that they're not calling an ambulance because this person's too potentially violent for an ambulance.
Thank you.
Representative Weber.
And just as a comment, when we drafted the legislation, that was the subject of a significant amount of discussion and compromise and listening to everybody. So we felt that the clinician at the emergency room was in the best place to assess what would be in their clinical opinion, in the best interest of the person being transported. But the folks doing the transporting got to decide on the level that they felt comfortable with for both the safety of the patient and the safety of their personnel, which was of great concern to everybody. So that's kind of the way the decision-making tree came out. And obviously, I think the clinical decision at the emergency room level would drive some of the assumptions about what was needed in terms of restraint for transport.
Representative McDonald.
Thank you, Mr. Chairman. So in terms of designated receiving facilities in the state, there's 7 of them. Is that correct? Okay. Follow-up?
Follow-up, yeah.
Cypress Center, where is that located?
Yeah.
Manchester.
Manchester, okay. And another follow-up, Mr.
Follow-up, yeah.
So it seems like, and understandably, this is pretty much the population centers of the state, but the western side of the state, the more northern areas, what happens up there? They have to be transported to Franklin or something like that, or to, I'm not sure where, but.
They'll be, so the way that the care traffic control team works now at New Hampshire Hospital, we receive all the IA referrals and we make referrals out to what we feel would be the most appropriate DRF. And we do take into consideration how close that DRF is to that patient's home. And to your point, there are fewer available DRFs in the North Country. And so, you know, and we also have to take into consideration the wait for any particular bed. I mean, we don't want someone waiting in the emergency room longer than necessary. And so we want to move them to a DRF bed as soon as possible. But yeah, there are some areas geographically in the state that don't have as many DRF beds available.
And one more follow-up.
Yes, follow-up.
Are there thoughts about perhaps developing anything in the more western areas or northern areas, or is that maybe down the road?
The state's always open to other facilities who want to apply for certification as a DRF.
Thank you.
And just to add to that, Dartmouth is opening 4 DRF beds? 5, thank you, 5 DRF beds in the next couple of months, Marissa. So yeah, so at least we'll have a few more in the Dartmouth area.
Thank you.
Representative Weber.
I will just say that it is a matter of some grief to me, but Cheshire Medical Center had an 8-bed psychiatric unit, and when our psychiatrist retired, we were unable, my understanding is that the hospital was unable to find another individual to take on the job of supervising that unit. And the unit has now obviously been repurposed as something else, and it's a real loss to the southwestern portion of the state. But there it is.
No further questions? Have anything more for us? Good. Thank you. New Hampshire State Commission on Aging Annual Report. Lori Duff, Rebecca Sky.
Send it out. Yes. Hello, good morning. Thank you for having us today. My name is Rebecca Skye. I'm the Executive Director of the New Hampshire State Commission on Aging. And with me is Lori Duff. She is the Vice Chair, Chair-elect of the Commission on Aging. Sue Ruka, unfortunately, is out with health issues. Lori Duff is the Director of Senior Services at Easter Seals, and we're very grateful to have her on the commission. So I thought I would start. I'm going to take you through the report. I start with a little bit of a brief history on the commission. So the commission was established during the 2019 legislative session. The key charge for the commission is to advise the governor and legislature on policy and planning related to aging. We study areas of public policy and, that impact older adults, and annually produce a report on our findings that includes recommendations for change. The report is just one way in which we carry out our charge. We also have a fabulous newsletter that is edited by a volunteer that comes into your inboxes every month. It also goes out to many New Hampshire citizens who find it of value. And so in our brief time, I'm going to give an overview of the organization of the annual report, priority recommendations for the upcoming session, and areas where discussions by policymakers such as yourselves are needed to develop consensus. So if you'd like to follow along with me, on page 3 is a message from myself and the outgoing chair of the commission, Sue Ruka. The key message that's in there is that New Hampshire right now is experiencing a significant demographic shift whereby our communities are increasingly comprised of more older adults and fewer younger people. The shift is not only happening fast, but it is a permanent change to the makeup of our communities. It's not just baby boomers aging. It is driven by declining birth rates and people living longer lives. And it's a trend that's not going away. So it's time for for all of us to start seeing New Hampshire's older adults as a valuable natural resource our state has. We can amplify the opportunity through reforming our systems of care, employment models, housing and transportation options, and harnessing the economic engine and talents of our increasingly capable older residents. So page 5 includes the vision, mission, and values of the commission, and lists the commission members who were on the commission at the time this vote was reported upon. Page 6 highlights the activities of the Commission on Aging over the past year, and page 7 begins the dive into the priorities the Commission on Aging has identified for New Hampshire. These are the same 4 priorities that we had last year. It's strengthening systems of care for healthy aging. It is growing the direct care workforce. It is advancing age-friendly policy systems and environments, and calling for the development of a multi-sector plan for aging in New Hampshire, what we're calling an Age Well and Age Plan. So in the next pages, we, for each priority, we make a case for the priority, and then we list recommendations for policy changes that will strengthen our state. For reference, those pages are outlined, have a blue box that outline the recommendations. Many of the recommendations do have a price tag. Others have less of an economic impact. For instance, one of the recommendations under the system of care is to make the life safety inspections and the complaint reports with findings publicly available in assisted living facilities, like is already available for nursing facilities. So starting on page 24, we highlight the progress made on each priority over the last year. Some are programmatic advances, but there's a larger emphasis on the changes that are a result of changes made by the legislature to public policy. So page 34 starts our appendices. Appendix B on page 35 provides an overview, comments made at the 2024 Long-Term Care Summit in Portsmouth by 2 economists, looking at how long-term services and supports are funded in our state. It also includes additional research by the Commission to round out the information that was provided. This appendix calls for policymakers to look at diversifying funding streams for Medicaid programs that provide long-term services and supports to low-income individuals. The confluence of a larger older adult population and increasing trends of poverty amongst older adults creates the potential for a larger pool of eligible individuals and suggests significant more dollars will be needed down the road for these programs. Appendix C, the final 2 pages of the report, provides a demographic snapshot of the older adult population in New Hampshire. The projection chart on the bottom of page 40 might be of greatest interest. It really shows the growth of the older adult population that is expected here in New Hampshire. And that data was developed by the Department of Business and Economic Affairs. Now I'm going to turn the microphone over to Lori Duff, who's going to take a little bit more of a deeper dive on some of the priorities in the plan.
The first priority I wanted to speak about is strengthening the system of care for healthy aging. A system of care for healthy aging was established in House Bill 2 during the 2023 legislative session. This
Looking at a particular page.
no, sir. No.
You could. It would be page 8.
This recognized that there are an array of needs a person might experience as they age here in the Granite State, and that ensuring the availability of services was in our best interest. The changes made in that House Bill 2 have been helpful towards shifting the reliance on long-term supports and services, facility-based care, such as nursing homes, which is the most expensive setting for care, to more home and community-based care. Continuing to strengthen the accessibility of these services will continue to support a shift away from facility-based care, avoid unnecessary hospitalizations, and improve quality of life for older adults in need of support and their caregivers. There are a number of good ideas you'll see on page 10 and 11 to strengthen the system of care. Given that this is a very tight budget year, we trust that you will see the importance of this and attend the Bureau of Aging and Adults Services budget, in particular, the person-centered counseling funds, and in the prioritized needs budget, choices for independent rate increases, amounts based on required rate study per the last House bill to support CFI rates, guardianship services to address increase in demand for slots and increase in reimbursement rates. There are not enough guardians in the state. Congregate housing, continuation of programs funded via Chapter 79 laws of 2023. I'm going to discuss now the second priority in the Council on Aging's report is to grow the direct care workforce. We all know of the workforce crisis our state is experiencing. The Commission focuses on the direct care workforce because, as often low-wage workers, they have unique needs that are larger than workforce initiatives that aren't attended to, and they are critical to the well-being of many older adults. It doesn't matter how deep your pockets are to pay privately for services. New Hampshire does not have enough workers willing and able to provide the care. Data cited on page 11 suggests that New Hampshire has 28 home health care workers per 1,000 adults aged 65 and older, compared to the U.S. average of 61 workers per 1,000 adults aged 65 and older. On page 13 and 14, provide suggestions for growing this workforce. Likely you will see this session a workforce omnibus bill that includes ideas for investments into all types of healthcare workers, including direct care workers. Another initiative addressing this issue is New Hampshire Needs Caregivers. Out of consideration for time, I'll point to pages 16 and 17 for policy recommendations that will serve to support the financial well-being of older adults by helping them to stay in the workforce longer. Address New Hampshire's housing challenges with innovative ideas for expanding needed housing options for both the older adults and the workforce housing. Improving community transportation, expanding utilization of age tech to stay in homes longer, and increasing civic engagement and mostly decreasing social isolation. The final call to action in the report is for policymakers to advocate the concept of developing a multi-sector plan on aging, what we call Age Well New Hampshire plan. What we've done in this report is a start based on the study the Commission on Aging has done. But we need to have a larger audience. Policymakers like yourself participate in a 10-year visioning process to address the impacts of the rapidly changing demographics our state is experiencing, to best take advantage of the opportunities of this change, as well as to address the challenges. We will be approaching the new governor to create an executive order calling for this multi-sector plan on aging. We hope that you will see the need as well and also call for the participation in this planning. We will be reaching out to you over the coming year to learn your ideas of what would make New Hampshire an even better place to age. And we hope that you reach out to your constituents to be asking a similar question. The more prepared we are, the more resilient we will be. We're happy to answer any questions.
Representative Merchant.
Thank you for this report, and thank you, Mr. Chair, for taking the question. I really have a passion for this for multiple reasons. But one of the things I'm looking for is the demographics, and you talked about that earlier. When you look at the demographics, and we have such a disparity between the elderly and the ones behind them providing the service, is there any thought or place that people can go? Because many times a spouse could become a caregiver, somebody in the family could become a caregiver. Is a way for them to be compensated for some of the work that they're doing? And then also, is there any funds available to help them stay in their home, either bathroom facilities, ramps, getting into the house? It's very expensive to go to institutional care. They don't want to go there. It's very costly. So what can we do to help offset some of that cost?
Do you want to answer the first part about funds for paying for people in their home?
Yes, currently there are funds through the Choices for Independence program that enables a loved one or a family member or a friend to be paid through that program to take care of an individual. There's no other program other than that one that is currently paying, and they are. The individual needs to be hired, the family member or friend needs to be hired by an employer that is providing that service. And then they get a certain number of hours that's provided to them. So but that is the only one that I'm aware of that's happening for caregivers.
So Easter Seals does do that. Yeah.
Yes.
And regarding the second question about home modification, there are other states that do put more funds into home modification. I'd actually, if possible, if Wendy might be willing just to talk a little bit about it. The commission itself is a 26-member commission that has representation from 8 state agencies. I do know that DHHS had utilized some COVID funds during the pandemic for a home modification program that people who were participating in the CFI program were able to take advantage of. I don't know about the continuation of those funds. I see Wendy shaking her head. I also know that there are some other programs. I know Cheshire County sees the benefit of helping people to stay in their communities, and so they have dedicated some of their own county funds to that purpose. It's a referral program through social service agencies that allow people to get access to those funds to do some home modifications. But it's an area where our state needs to have a whole lot more development happening.
Representative Weber.
And in full disclosure, I am the Cheshire County member of the Commission on Aging. And in our county, it became clear to us that investment in home care saves us a lot of expenditure in nursing home care. And I guess my question to you is in part the purpose of the multi-sector plan on aging, Age Well New Hampshire, a way of creating something that is in the same nature as our 10-year mental health plan, where we are planning beyond an individual biennium. And as we heard in a number of areas earlier today, the argument and the documentation for the expenditure of certain funds up front, which will then be an investment that provides significant savings down the road. Because with a 2-year biennial budget, it's always easiest to look at what's going on right now and not plan for how we can leverage advantages going forward.
That's absolutely correct. And that's a little bit of the point of that Appendix B that I pointed out is that there is going to be increasing needs and increasing strains on our programs and services, and we need to look further out than 2 years. We need a 10-year vision, and that creates benchmarks along the way that towards the change that we need to have in our state. We can't turn on and off that light switch. There needs to be gradual change that happens as we go along.
You have 2 minutes.
No, I just want to make
In this part of the room, not over there somehow. Okay, go
It's
ahead.
Mr. Chairman, I just want to make a public comment that it's been a privilege and an honor to serve on this committee and in the legislative body. So thank you.
And both to you and to Representative King, thank you so much for your service. Don't throw out your lawn signs, just in case. Thank you. And with that, we're finished. Thank you. And because you've been so wonderful, I'm giving you December off.